Can you see the PowerPoint?
Ventricular arrhythmias, yes.
So there are different types. You get ectopic, escape, idioventricular, tachycardia, fibrillation, and long QT syndrome. That's also another step one
Yes.
that you need to know, and Brugada syndrome. So let's start with ventricular ectopics. It says that if the depolarization of the ventricle originates outside of the normal conduction pathways, the wave of excitation will be slower and less organized. We've mentioned this many times about the ectopics, how when it originates from elsewhere, we will see some sort of a different morphology, right?
Mm-hmm.
So here's, I say, the PRE interval will help distinguish between the atrial and AV node ectopic. Atrial and AV node ectopic. As in the atrial ectopic will have a PR that is not terribly short, but it's not sinus. Whereas the AV node will have a very short, and before, that could be before, during, or after. Okay. But those are atrial and AV node. We're talking here about ventricles. So when we talk about ventricles, what we're going to see is we're going to start early. That is going to be followed by a pause. There will be no P wave because it's going to be initiated by the ventricles.
There is no P wave.
Yeah, there's no P wave.
So does that mean that the atrium doesn't contract, or does it contract during the QRS, like during the ventricular contraction?
So that's what we're going to look at here, because what I'm mentioning is I'm comparing here atrial and AV node with the ventricle ectopic. Okay. So in a ventricular ectopic, we're not going to see a P wave. And the QRS is going to be broad and bizarre. We'll check out what characteristic that details. Okay.
Okay.
We'll see how that compares to having a P wave inside a QRS, like you mentioned.
Okay.
So the ectopic beat occurs prematurely prior to the expected sinus node initiated QRS. We'll see what that means. Like we mentioned before, wide and bizarre is the QRS feature for the ventricular ectopic. And these are the different types of ways you can call it. The abnormal depolarization leads to an abnormal repolarization. So the T wave is opposite in polarity to the QRS. So here we have an ECG lead, and it's showing us a P wave QRS, a P wave QRS, a P wave QRS, all the way, a P wave in QRS. If you take a look at the rhythm, we have 1, 2, that's 3 squares. From here to here, that's 3 squares. And every single one of them is, 3 squares.
Mm-hmm. Yeah,
so
that's pretty.
Here's
that
3 squares in 1. And here, what do we see? 1, 2, 2.2.
So shorter.
So it's anticipated. It happened before. Okay. So that's one of the characteristics. Like it says here, the feature is starts early, followed by a pause. So that's another characteristic. Let's see the pause. That's the pause. From here to here. Do you see the pause? You have 1, 2, 3, 4.
Yeah.
That's the pause. So it depolarizes sooner. And the pause is because it's a compensatory pause. All right. So the beat that comes after the pause will have recruited all the channels, have had more time for filling, increase the stretch. Thus, after the pause, there will be a forceful contraction after ectopic. So it's mentioning that this after this beat that comes after the the ectopic ventricle, ventricular ectopic, it will be a little bit more powerful. Powerful meaning having more amplitude. I do not see much difference between the other ones, but yeah, it's not that. It's not. It doesn't have that much. It's one of the highest. Has the highest amplitude, but it's not that big of a difference.
So it
Okay.
says, so in your notes, it says not a concern, like not a concern for the patient. So if you catch this in an EKG, then you don't do anything about it?
Where does it say that? Not a concern. Oh,
Oh,
here, not a concern. Yes. So let's see what it says. Earlier than anticipated, not initiating the SC node or AV node, no visible P wave, obviously, because it's anticipated. There's increased R wave amplitude all the way up there. Stronger vector. Does that mean the heartbeat is stronger? The question is no.
okay.
It's just that you're getting a net vector that'll be higher, but less forceful contraction. So
Okay.
does not mean heartbeat is more powerful. The beat has become earlier, less time for filling, which means there's less of a stretch by the cardiomyocytes, which leads to a less powerful contraction, therefore less stroke volume.
Okay. Now, now it says not initiated by SAN AVN. Does that mean that it's not initiated by the? Obviously, it's not initiated by the by the by the SAN AVN combo, but is it initiated by the AVN by the AV, or is it just initiated by itself?
The ventricle has the capability to contract itself too.
Right. Well,
Sorry,
all the cardiac
to
cells have the capability to be pacemaker, possibly.
exactly, exactly. Sorry, that was my point. The pace, they have a pacemaking ability.
Capability, yes, yes,
Yeah.
that's correct.
So, um, so yes, and the features are very important, and they are different from from what you mentioned before about having an. How do we know if there's not a P wave inside? Because the morphology itself is different. You have a you have a the repolarization. It's inverted. You have that compensatory pause, which is very characteristic. Okay, and the QRS is wide, right? So what can cause a trigger in this ventricle and produces this ventricular ectopic? So it says here that enhanced normal activity in his Purkinje system. So the sympathetic stimulation or catecholamines can cause this. Abnormal automaticity in the ventricular myocardium, ischemia, electrolyte imbalance, injury. But this will also demonstrate other stuff too. It doesn't just show as this. And yeah, those are exaggerated by this type, worsened by alcohol, caffeine overload. Except instead of infarct, ischemia, hypertrophy, or heart disease, ectopics are usually considered benign. They have no impact on longevity and do not require restricted activity. All right? So look at this one. It says that two different types of morphology is unusual. So imagine this being a lead 2 and you get this type of morphology. So this just means that you're having multiple ectopics at different locations. So multifocal ectopics initiated indicates that more than one ectopic site. Does that make sense? Okay. Okay, good. Excellent. More ventricular ectopics. So here we see the just early, we see the P wave happening on this one. Very unusual. Also sometimes called fusion beat. Happens to come at the same time as a P wave. All right. Good. All right. So this is one of my favorites. Hang on. Is it this one? This is Torsade de Point. I think it is. So this is my favorite. Torsade de Point is one of my favorite types of ectopic beats. Sorry, type of arrhythmia. So R on T. So imagine a QRS complex that occurs, and then another one occurs right on the T wave, right on the T wave. So the T wave is vulnerable because it's a repolarization period. Okay. So the fact that when this happens, it can provoke ventricular tachycardia or fibrillation. Okay. So, like I mentioned before, it's a vulnerable period because all the ventricular myocardium has fully not all the ventricular myocardium has fully repolarized. It usually occurs with ectopics due to early after depolarization, so happening after a normal QRS complex, and it's right at this point. This is the R on T that it sets it up, and you get this very unique morphology.
Okay, so basically what happens is that you have a QRS complex, and
Yep.
then the ventricles they depolarize doing repolarization.
Can you repeat the question?
So okay, so you have a normal QRS, right? So the ventricles have contracted, and now they need to repolarize, which is what the T wave is.
Right.
But then before they finish repolarizing, they depolarize again.
Yep.
Okay.
Yep. So just remember that repolarization if I remember correctly, can be split into two phases, the absolute and the other one I can't remember the name. Absolute, and there's a refractory period that is absolute, which you as much as you intend to.
Right. Nothing. Yeah. It's not going to repolarize it.
Exactly. And then there's that other vulnerable point that if you have enough strength, you can initiate an action potential. So that pretty much what happens is that. Okay.
Okay. And once again, this is initiated by the Purkinje fibers in the ventricle, in the ventricular
This
area.
could be initiated by the ventricular ectopic,
Okay.
right?
Okay.
That is out of the. It's like another system. Uh, it's not within the system, electrical activity system, but somewhere else in the ventricle induces an ectopic beat. Okay. And if you can see, it normally is triggered because there has been a pause. So this one to this one, there's 2 squares.
Okay.
And here we see longer than 2 squares. So it's often followed by a pause that the ventricle recognizes that it took too long, and so there's no sync between the atria and the ventricle, and so the atria depolarizes the ventricle, but the ventricle, let's say they got this signal late, and so the ectopic beat initiates right within that T wave. Okay. So yeah, it's called dance on a point, tosado point, because it looks like that.
And then how do you fix it?
We'll take a look. Oh, it doesn't show. Darn. How do you fix it? I don't remember, but I actually don't remember this. How to fix this. But hopefully we'll see it later.
Okay.
So ventricular escape. So this means that it has not received, like we mentioned, it has not received the signal, and so the ventricular, like to not to compensate, but to generate an electrical impulse, it will initiate its own beat, right? So since impulse originates in the ventricles, the QRS complex appears the same as a ventricular ectopic. It's not premature, like it is on an ectopic beat, and the heart is very, very slow, and is often insufficient to perfuse the organs. This could be 20 to 40 beats per minute. So it's very easy to recognize, right?
Yeah.
Ectopic comes early when not needed, but the escape comes late when it is needed to pacing has failed. That makes complete sense. So the SA node can initiate a beat, but it never makes it to the ventricles if blocked at AV node. The ventricular escape beat might occur. The features are broad and bizarre. The T wave is opposite in polarity, and remember that it's not premature. Okay, I think it's very easy ventricular escape to observe.
Mm-hmm.
Okay, so now we have accelerated idioventricular rhythm. I
Mm-hmm.
think the point idio means there's no known cause.
Mm-hmm.
Um, escape pacing or means accelerated, often seen after a heart attack. It will start reperfusing with this rhythm. So there are more than 3 ventricles beat with rate of 60 to 100 beats per minute that are initiated by a long coupling interval. All right. Often associated with fusion beats, which means the P wave and the R wave are together. The P wave and the QRS are together due to the depolarization of ventricles by both SA node and ventricular myocardium, like I mentioned just now. All right, let's see what's characteristic about this. So I see it being more having a bigger amplitude, and the morphology is the T wave is also bigger.
Mm-hmm.
It says that it's well tolerated with a rate of 60 to 100 beats per minute. Fusion beat depolarization from SA node ventricles at the same time. All right, give me 1 second. I'm trying to look. Here's the R wave. Fusion. I think the F refers to fusion beats. Yeah, I don't remember much about this. I don't remember being that characteristic and that important. But look at the different types you can get. This is what you can get with if you put a lot of digitalis in someone.
Wow.
Yeah. So ventricular tachycardia. So greater than 100 beats per minute, 3 or more ventricular complexes or QRS that has a heart rate greater than 100 beats per minute.
Mm-hmm.
Again, you can be seen with MI. Nothing much to see. Each beat of ventricle has the same morphology.
Now, you're still getting P waves for this, right?
If you give ventricular tachycardia, I do not think so.
Okay, so you're just okay. So there it is. You're not.
That's the thing. There's no P wave.
Oh wow. Okay, so that's VTAC.
It says that it looks like a ventricular ectopic, but the
Mm-hmm.
heart rate is going to be greater than 100.
Okay.
And
And
there's no
it basically is a ventricular ectopic.
right, and there is no pause. Ventricular ectopic is just one ectopic beat.
There's no pause. Okay.
Right, so it's very consistent.
Okay. And this is one of those things that you can shock, I believe.
So yes, so here you see the consistency
Mm-hmm.
and retrograde atrial depolarization. So it's telling, it's telling us here that we're observing that there's some atrial depolarization occurring because we see it being different here from here and here and here. And then the P wave, it's telling us those are P waves.
Okay.
And then we'll come back to normal. Okay.
Okay.
So ventricular tachycardia, it's like the tachycardia that we're observing has been overtaken by the ventricles. So the ventricles are producing that tachycardia,
Okay.
not the P wave.
Okay.
Okay, the P wave is trying to, hey, let's get back in rhythm, and that's how it does it here. Does that make sense?
Mm-hmm.
So in this case, it's non-sustained because it's not consistent throughout, but it is consistent throughout a period of time.
Okay.
Some forms of it, ventricular tachycardia are sensitive to catecholamines. Like you mentioned, it's a medical emergency and often degenerates into ventricular fibrillation. And obviously, because you have tachycardia, the heart does not fill properly, and therefore your cardiac output is not maintained.
Okay.
So let's look at this one. It's giving us a question here. Ventricular tachycardia. So we are observing the ventricles initiating the beat because there are no P waves.
Mm-hmm. So, okay, now physiologically, are there no P waves, period, or are they, once again, or are they being obscured by the QRS complex?
It could be the case. It could not be the case. Like in here, we do not see a P wave happening. In here, we can suggest because the P wave has, oh, darn. We do see the P wave before and after, but not throughout the ventricular tachycardia. However, my notes are saying here that, wait a sec, you do see the P wave. It's inside the QRS or the T wave, actually, because you know it's different from the first one. Does that make sense?
Mm-hmm.
And so let's look what it says here. So the rhythm is irregularly irregular because we do see an R to R difference in the interval right here compared to the other
Okay.
ones.
Okay.
So that by itself tells us that the rhythm is not consistent, and so the timing should be the same. In here, we do see timing being the same as here. But because here we do not see the timing be the same, that gives the name of fibrillation, where there's no pattern. So this is atrial fibrillation.
Mm-hmm.
So we'll conduct it down to ventricle that goes through an accessory pathway. All right, so here we have polymorphic ventricular tachycardia. That just means a lot of different morphologies that are inducing the ventricular tachycardia. So here we see tachycardia with a lower amplitude, and here we see with a greater amplitude, but we all see the consistent being the same. Did you see that?
Mm-hmm.
So more than one morphology present. Can be sustained or not sustained. But throughout that period of time that you're having the tachycardia, the consistency is sustained. That's the main difference. Here,
And then on the top one, they like it fixes itself there at the end. Do you see?
right.
Okay.
Right. Maybe a pacemaker was given right at that point, right? Sorry, not a pacemaker. They shocked the patient at that point.
Or they gave him adenosine. They could have also given
Right,
him
right.
a chemical.
So here is, like I mentioned before, it's a subtype of ventricular tachycardia, torsade de pointe. It's life-threatening, obviously. Unique undulating QRS pattern, twisting of the dance of the points, occurs with a long QT syndrome. Remember I mentioned to you there's a prolongation, and that's because the QT was longer. Let me see where it is. Oh, yeah, the longer the QT, the greater chance of your the longer your repolarization period, meaning the more vulnerable you are to having a beat occurring at that point. Does that make sense?
Mm-hmm.
Proceeding by lengthening of the QT interval, yeah, associated with. I do not see. Hopefully, I see the treatment. And here is the explanation of the repolarization. It also has to do with the way the muscles are depolarized. That explains the lengthening. Okay.
Mm-hmm.
Here it is, caused by prolonged repolarization and increased susceptibility to the early after depolarization. Okay. Good. Yeah, I don't see the treatment. So, okay, now we see the ventricular fibrillation. So it's called chaotic pattern of electroactivity in the ventricles. And we see many different locations that are inducing the electroactivity. So it has to be treated right away. And I guess here the morphology is different, completely different. Atrius job is not seen. Ventricles are contracting. ST elevation, sign of cardiac. So I'm trying to think and compare this with the ventricular tachycardia. How would you describe the difference?
Between that and the ventricular tachycardia,
Yeah.
I would say that this is less organized. I mean, it's not. First of all, it's yeah. This I mean, this looks different because with ventricular tachycardia, you were still getting like clean looking QRS complexes, whereas here, I mean, it just looks like a sawtooth.
And if we look at the entire chest ECG lead here, we also observe that first, okay, we could tachycardia could have different polymorphisms, right? But the problem here is that it's not regular. At this point, it's regular, 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 but here, irregular. It's longer. And then stays about the same, but there's some irregularity here. So that's why it says here, where does it say? No recognizable pattern. Okay.
Mm-hmm.
So there are definitely many types of causes. Could be a congenital heart disease. It could be anything. Better chance of successful defibrillation. Congenital and acquired long QT. This has to do with the. Remember we touched on genetics.
Yeah, yeah.
About the LQT1, LQT2, and 3.
The potassium channels.
I think the one had to do with the heart. Two had to be with. Sorry, one had to do with people that do exercise. What was number two? Two had to do with hearing problems, I think it was.
I don't remember.
And 3, sleep, something like that.
But those genetic things are problems with the potassium channels, right? I remember.
So
like those genes
one,
like KC and Q1, that's a potassium channel gene, I believe.
So it says right here, the current. So this is a potassium current that is that it's found in repolarization. This is also found in repolarization. This is HERG channel. I actually worked and did an investigation on HERG channels.
Really?
Yeah.
Oh, that's cool.
Back at my university. And sodium channels. LQT3 is due to sodium channels having an impaired activation during that phase 1 when you're actually inducing the extra potential. So it's like you're not inactivating the sodium channel, therefore it stays a little bit longer, and so you're expanding that period of time. All right, so the QT, we've done it before, that calculation that you need to do to correct for the heart rate or the heartbeat. Acquired long QT can also be occurred due to drugs, cardiomyopathies, electrolyte imbalances, and what does it say here? The concentration blockers, decrease severity. Okay, I don't think we need to know this. Short QT, it's like a gain of function of the potassium channel, so they repolarize faster. That makes sense. The faster you repolarize, the shorter the repolarization period, the shorter your QRS. Sorry, the QT interval would be. And let's see here. Large increase, short rate rarely permits re-entry arrhythmia, because it's like you're allowing the heart to contract again, or the cardiomyocytes. And Brugada syndrome. This is also another characteristic type of syndrome. I'm not sure we need to know this, but it is well known. And it's giving us, it had to do with sodium. I remember it had to do with sodium channels being what it's being altered.
Okay.
And, oh, I don't remember this, that it had to do with unexplained nocturnal death syndrome.
Oh.
I actually have a friend who, of my age, that passed away at the beginning of I think it was late last year. They found him asleep and he didn't wake up.
Wow. I kind of want to die like that, so.
Yeah, but not at a young age, man. He was like 26.
I'm already not at a young age.
Yeah.
that ship has sailed.
Yeah.
Oh, man. Brugada syndrome. Okay, so sodium channels.
So there are three types. It's showing us the J point. There's a J point that we never discussed that we will later.
Okay.
But I don't remember much about this stuff. But it's very, very unique. But I just want to make sure you get a touch on at least the pathophysiology. Here it is. It can be caused by a mutation in the sodium channel.
Okay.
Of this type of gene.
Holy shit! At least 80 different mutations have been identified.
Where does it say that?
Well, second line.
Oh, 80 different mutations. Yeah. And yeah, decrease sodium channel and mutant channels due to low expression. Yeah, it's very. Some are temperature dependent. Think about that. So they worsen with a fever. And some can be induced by the sodium channel blockers, obviously. Cocaine, and this has to do more with the loss of function or less amount of the channels expressed. Cocaine, alcohol, antidepressants. So it sounds like it's Brugada's. I try to think of it as a SAD syndrome, where everything goes down